All right, looks like we are ready to go. Thank you so much for being here, for joining us this evening. We really appreciate you sharing your time with us. Understand that many of you have already had a very long day of work and still make the time to be here. So want to start off with a huge appreciation for your time. We have a full agenda for the hour, and before we get started, though, we will take some time to make sure that our interpreters are set up and that anybody who needs interpretation can get their computer or device set. So in our next slide, we'll walk through some of those steps. If you need interpretation to Chinese, Russian, Spanish, or Vietnamese, please use this little globe symbol on your screen and select the language appropriate for you. Si usted está con nosotros y habla español, pero necesita usar la interpretación, puede presionar el icono de un globito y ahí va a poder seleccionar español. Tenemos un intérprete que nos va a ayudar a traducir, a interpretar el material de esta noche. Thank you. And our agenda for tonight, we have an overview of COVID-19 with Oregon Health Authority. Once again, just really thankful for this partnership and to have him join us. We'll then move on to just giving some overview of some of the engagement work regarding mission, vision, and values for the Department of Early Learning and Care. And we'll end with some agency and program updates for you all. And just as a reminder, after we cover each topic, we will go ahead and spend a few minutes answering questions that are submitted through the question and answer feature if you're on Zoom. If you're on Facebook, please go ahead and enter questions in the comment section. We have ELD staff looking at those questions, and they're also making sure that we can address as many of them as possible. So with that, we will go ahead and transfer it over to Miriam, Cecilia, and Meg Carey, who is joining us from OHA. Miriam, would you like to kind of guide us into this next piece?
Absolutely. Thanks, Karina. Hello, everyone, and good evening. Thank you for joining us. My name is Miriam Cecilia. I'm the Field Operations Director with Office of Child Care. And also joining us tonight is Meg Carey with Oregon Health Authority, our Senior Health Advisor. We have a few updates to share regarding COVID. I do want to point out that some of the updates that we are going to share tonight are not yet in our Early Learning Division COVID guidance document. That document is going to be updated in fall, but we do want to just bring your attention to these updates as they come, as timely as they are, so that everyone is fully aware and has the information that they need. So one of those updates will be regarding COVID positive case reporting requirements, and Meg is going to talk to us more about that, as well as childhood vaccines and transmission community levels in each county.
Thank you, Miriam. Hello, all. Good evening. Thank you so much for inviting me back again. My name is Meg Carey, and I'm one of the Senior Health Advisors for the Oregon Health Authority's COVID Response and Recovery Unit. It is wonderful to be here again. And my colleague, Dr. Lara, will be joining the meeting tomorrow. So as Miriam reported, we are changing our reporting thresholds to represent high, unusually high absenteeism. Next slide, please. It is no longer required that childcare report every child or staff who is out with COVID. At this point, with community transmission so high, with variants that are so rapidly transmissible, it is no longer feasible, reasonable, or frankly helpful to report every person who's out with COVID. Rather, we would like to recommend that you all start reporting when there are unusually high numbers of staff or children who are out due to respiratory illness. So this is a wider swath of people, but it encompasses best practices for respiratory disease infection. And as we're coming into the fall season, which is hard to believe already, and with flu season, again, these are the best public health practices. And we recognize that not everybody's going to get tested right away. And so the local public health authorities would like to have some awareness on all respiratory illnesses for surveillance as well as support purposes. There are two different thresholds depending what kind of childcare program you are. For those of you who are home-based childcare programs, please immediately report to your local public health authority when there are at least three or more children or staff who are absent due to a respiratory illness or due to respiratory symptoms. If you are a center-based, recorded, or school-based program, please report to your LPHA when there are 10 or more children or staff absent to a respiratory illness. Again, symptoms of respiratory illness include the core symptoms of COVID that you're all very familiar with: fevers, chills, shortness of breath, new cough, or new loss of taste or smell. Symptoms of respiratory illness may also include congestion, runny noses, or a sore throat. Next slide. I put a link at the top here for your LPHA contact information. I know you all know this already, but I also appreciate that staff change. And please be prepared to give the LPHA the names and dates of birth of the individuals who are absent. You do not need to report when there are staff or children absent due to non-disease related reasons, holidays, activities, or other events. Again, the LPHAs really only want to know for communicable disease purposes. The LPHA also will only open a COVID outbreak when at least one of the people, child or staff who's out, has a confirmed or presumptive case of COVID. So we recognize that you may report illnesses that end up being RSV or the flu and not COVID. And again, that's helpful for the LPHA to support your programs and to be aware of respiratory disease surveillance, but they will only open a COVID outbreak if there is a confirmed or presumptive case of COVID. Next slide, please. Moving on to another topic, we'll take questions at the end for all of these topics. How exciting that COVID vaccines are finally FDA approved for young children. Next slide. We now have over 2 years of data of why it is important for our young children to be vaccinated. More than 2 million children 6 months to 4 years old have contracted COVID nationally over the past 2 odd years. In Oregon, more than 140,000 kids younger than 18, so this is a wider group of kids, have had COVID over the last 2 years. Of those 143,000 kids who developed COVID, 885 were hospitalized because of the severity of their illness. 69 developed multi-system inflammatory syndrome in children, which is a severe, probably autoimmune response to COVID. And 9 children tragically have died from COVID. Currently, proportionally more children 0 to 4 are getting COVID than older children, and this is likely due to the availability of vaccines and the number of older children who have been vaccinated. In addition, we know that the youngest children are more likely to require hospitalization. We also know that currently there are increasing numbers of childcare programs who are having outbreaks. We very much appreciate that the pandemic is nowhere close to being over, and you all are still managing outbreaks and infections in your programs among your children and staff. What we know from national data is that more than half of the children who were hospitalized for COVID, more than half of the young children 6 months to 4 years old who are hospitalized for COVID, had no underlying medical conditions or no other reason why they would need to be hospitalized. This can cause a very bad respiratory infection. We also know that deaths among children from COVID are similar in numbers or more so than other diseases that we have vaccines for. So our risk tolerance for the severity of COVID illness and the rationale for why this is a vaccine preventable, maybe not preventable illness in all cases, but vaccines reduce the severity and the likelihood of hospitalization and death, is for the same reason that we have vaccines against other childhood illnesses and for the same risks. And lastly, we know with the new variants of the SARS-CoV virus that causes COVID, reinfection is increasingly common. So if you were infected in the Delta wave or in 2020 or earlier in 2021, the chances that you get reinfected are really are more likely at this point. So we know again that simply having COVID isn't going to prevent you from getting COVID again, whereas vaccine can really help reduce, again, your risk of getting COVID as well as your risk of getting severe COVID. Next slide, please. And as we know with other illnesses, the more of us who are up to date with our vaccines and booster doses, the safer all of us are, including those individuals who, for whatever reason, cannot get vaccinated. Next slide. So there are 2 vaccines that are FDA authorized for children, and I'm going to review the efficacy data and the safety data, but first I wanted to just outline what are the major differences between these 2 vaccines. The 2 major differences are the number of doses and the size of the dose. Starting with the Moderna vaccine, all children younger than 18 years old get 2 doses of the Moderna vaccine 28 days apart. The size of the dose, or the relative number of the mRNA spike protein that is in the dose, varies by age, and oftentimes age correlates with body size. So the bigger your body, the older your body, the larger the dose you get. But again, all children get 2 doses. At this point, adults who have received the Moderna vaccine are recommended to get 2 doses, 28 days apart, and then a booster at least 5 months after that. In contrast, for the Pfizer vaccine, children 6 months to 4 years of age are to get 3 doses of the vaccine, 3 doses each separated by 3 weeks. The size of the dose is a little bit smaller, and that may contribute to why 3 doses are needed to reach the same effect as 2 doses of the Moderna vaccine. In addition, we know has been the recommendation now for some time, children 5 years old and older, all the way through adulthood at this point, are recommended to get 2 doses of the Pfizer vaccine and then a booster dose 5 months later, at least 5 months later. So young kids, 3 doses of the Pfizer vaccine, older kids, 2 doses, and then 5 months later, a booster dose. Similar to the Moderna vaccine, the older the child, the older the person, the larger the body, the higher the dose, the relative dose of these vaccines. Another thing that I just want to point out is that the way that the studies were conducted, Moderna grouped 6 months old to 5 years of age in their young child dosing group, and Pfizer grouped 6 months old to 4 years of age in their young child group. So if you're a 5-year-old, and it depends if you're going to get the Moderna vaccine or the Pfizer vaccine, but 5-year-olds would get 2 doses of the vaccine, and then if they have the Pfizer vaccine, they'd get the booster. If they have the Moderna, again, they would not get the booster. A lot, it's written down, and I also included the link to the OHA vaccine and booster information website, which also explains all of this information. Next slide, please. Oh, one more thing I want to say on that slide, forgive me, is that the vaccines are not interchangeable. So except in exceptional circumstances, you should finish the vaccine. You should finish the type of vaccine with the vaccine that you started with. So if you got your first dose as a Moderna, you should get your second dose as a Moderna. If you got your first dose with a Pfizer, you should get your following 2 doses with a Pfizer if you're 6 months to 4 years of age. Next slide, thank you. The most common reactions were the same for both vaccines, and far and away, the most common reactions are exactly the same most common reactions that happen with all vaccines: pain at the injection site, fatigue, drowsiness, headache, and irritability, depending on the age. There were no cases among any of the trial participants for both vaccines of myocarditis or pericarditis, the inflammation of the lining of the heart. No cases of severe anaphylaxis or severe allergic reaction to this medicine, and there were no deaths among any of the children in the trial. So this is incredibly reassuring safety information. It also mirrors the safety information for older individuals with these vaccines. We know these vaccines are incredibly safe and well tolerated. The Moderna vaccine did have an increased risk of fever, especially after the second dose in the trial participants. The average duration of the fever was 1 day. Again, it was more common after the second dose, and I included the percentages of folks who got fever. So 16% of the children in the Moderna study got a fever after the first day or the second day, most after the second day, versus 6% of the Pfizer study participants. So clearly more kids in the Moderna study got a fever, but again, this is the minority of children who developed fever. Next slide. In terms of efficacy, the primary outcome that these two vaccines were looking at was not preventing COVID, but rather the ability for these vaccines to cause an immune response, to cause antibody production that we know is protective against COVID. And the reason for this primary outcome measure being immunogenicity instead of preventing COVID, is that we have a year and a half of data that in those individuals who can produce antibodies to COVID, they are protected against COVID, and they're particularly protected against severe COVID and hospitalization, and probably long COVID as well. And so part of the goal of this is that we have so much data, we don't need to repeat the data we already know. We can rely on the data that we already have. And what they found, both Moderna and Pfizer, is that their vaccines were at least as, if not more effective in producing the antibodies protective against COVID among young children, the 6 months old to 4 or 5 years, as they are among the 18 to 25-year-olds. And so again, this met the requirements that these vaccines do what they're supposed to be doing, and they work as well in young kids as they work in older kids, or young adults, I should say. These studies also looked at preventing symptomatic COVID illness. So they also included this as a secondary measure. And this was looking at individuals who test positive for COVID and have at least one symptom of COVID. So it could be very mild COVID. And what they found is that these vaccines have similar effectiveness in young children as for the other ages. So they work just about as well in young kids at preventing COVID, any COVID, as they do in older ages. What we all know now, and I appreciate this is a bit of a changing of the goalpost, is that we know our vaccines are not 100% or even 80% effective at preventing any COVID illness anymore. They certainly reduce the risk of developing any COVID, but some people will get COVID despite being vaccinated. These vaccines are primarily effective against the most severe outcomes, the things that we worry about the most: severe COVID, COVID requiring hospitalization, COVID requiring ventilation, long COVID, and probably multi-system inflammatory syndrome in children as well. The efficacy of the Moderna vaccine and the Pfizer vaccine is published. You can see the differences in the numbers, but you actually cannot compare them because of the few number of trial participants who got COVID, despite these being studied during the Delta and Omicron surges. And so when the numbers of people who get COVID is smaller, the variability or the reliability of those efficacy estimates is less reliable. So because of the small numbers of people, because they were studied in slightly different timeframes, and because of the relatively short timeline of follow-up, you can't compare the effectiveness. But what we know, again, is these vaccines are as effective in young children as they are in others. And the reason that the timeline was so short for follow-up is, again, because the primary outcome measure was immunogenicity, or the body's ability to produce a response to vaccines. And we know that happens about 2 weeks, 10 days after getting your vaccine dose. So studying it for a month and a half or 2 months is sufficient to determine whether your body's going to mount an immune response. Next slide, please. Third topic is infection prevention. So this is information that you all know and you've already been implementing, but just to reiterate, infection prevention strategies are the same as they've always been, and I'm going to spend a little bit of time talking about what we do now, knowing that we can adjust our infection prevention layers depending on what the COVID transmission is in our community. So again, every childcare program should consider policies and practices that best support every child and staff's health and well-being, recognizing that individual health conditions and social inequities are going to place some people at higher risk for severe COVID. Given that, some childcares may choose to implement universal masking at all times to promote the the universal acceptance of that within their programs, and that's totally relevant. It's certainly very relevant now when there's high levels of COVID, and it's going to be very relevant in the fall and winter seasons when there's other respiratory infections. We know that the cases of respiratory syncytial virus, RSV, as well as flu plummeted. They were really suppressed when we had people wearing masks. And that's a better thing. We know that kids can be hospitalized and adults can be hospitalized for flu as well as young kids can be hospitalized for RSV. Next slide, please. So the layered prevention strategies are still the most effective ways to protect against COVID as well as other respiratory infections. Vaccinations and booster doses, I know I've repeated this a lot, but they still remain our primary method for reducing the risk for severe COVID. Staying home when you're sick, getting tested if you've been exposed or if you develop symptoms continues to be important to reduce the spread. Wearing masks when indicated, and remaining in smaller cohorts, again, to reduce the spread. Continuing to maintain ventilation in your programs. We know this is not only important for reducing the spread of COVID and the transmission of COVID, but it is increasingly, we have data about how important fresh air is to our overall health and well-being, our cognition, our awareness, our physical health. And then, of course, similarly, hand washing, covering our noses when we sneeze and our mouths when we cough, and keeping clean remain cornerstones to infectious disease prevention. What we recommend at this point is that programs implement more or enhanced prevention strategies depending on where they are in the CDC's COVID-19 community levels. So when you're at the low community level, continue your core standard practices. When you are at medium or high COVID community levels, consider either adding more layered prevention strategies or enhancing the ones that you already have implemented. When the COVID community levels go down, we recommend removing each enhanced strategy one at a time, because that gives you a chance to see the impact on your communities. And if removing this prevention strategy resulted in more cases of COVID or more respiratory illnesses, it might be reasonable that for whatever the factors are in your individual community, it's important to keep that prevention strategy implemented for a little while longer. If you remove it, there's no more illness, kids and staff seem fine, then you can go ahead and remove the next one. Next slide, please. This is a graph we created, kind of outlining the core prevention strategies and how to enhance or add some during medium and high COVID levels. So again, vaccination and booster doses, relevant for regardless of what the COVID community level is. Symptom screening and isolation, important regardless what the community level is. When there is medium or high community levels, though, have a lower threshold for testing when you've been exposed, for testing when you have symptoms, because we know that COVID can be transmitted asymptomatically, and sometimes increasingly recently, it is presenting with very mild symptoms. So it can be hard to know when you have COVID. In terms of masking, the standard practice is to continue to wear a mask indoors for the 5 days following a 5-day isolation at home, and for the 10 days following a known exposure to COVID. Again, we don't recommend quarantining anymore in childcare settings, but if kids can wear a mask, if staff, it's important for staff to wear a mask after they've had a known exposure to COVID. In the medium COVID community level, consider masking for those who are unvaccinated, for those who are at high risk of severe COVID, and for those who are working with others who are at high risk for severe COVID. At the high COVID community level, we recommend universal indoor masking regardless of vaccination status, because there's just so much COVID transmitting in the community that it's important that everyone participate in reducing the spread. Ventilation, again, standard practice. In medium COVID levels, consider if there's ways to increase ventilation, whether it's adding fans or opening windows. At high COVID levels, really consider what you can move outdoors. Cohorts, again, standard practice. In medium COVID levels, increase your awareness to where there might be places of crowding, at drop-offs, at pickups, as kids are transitioning into and out of classrooms, and work to limit the crowding. At high COVID community levels, pay more attention to increasing physical distancing. And I say this knowing very well that physical distancing for young kids is sometimes not recommended and is sometimes impossible to implement, but consider ways in your program where that makes sense. Again, to reduce the risk during those short time periods, hopefully short time periods of higher COVID transmission. And then hygiene and cleaning obviously is for all times. And last I checked earlier this week, the Office of Head Start was still reviewing its masking requirement. At this time still has an indoor masking requirement. I appreciate that some of you are likely more up to date than I am on where that rule stands at this point. Next slide, please. This is a map of the current COVID community levels in Oregon. And forgive me, I realized that I neglected to put the key on here. I'm so accustomed to this map, but I did not put the key. So I will say it verbally, and I have emailed ELD a revised copy that has the key on it that hopefully they can send out to you all. Green is low community level, yellow is medium community level, and orange is high community level. The CDC updates its community levels every Thursday at 11 p.m. Pacific time. As you can see now, at long last, again, we have some communities in the green, and we have more communities, more counties in the orange, and then some counties who still have a very high level of COVID transmission. Next slide, please. The next two slides are resources. Most of these you should already know. I'm just going to highlight a few of them. We still have the Oregon Health Authority COVID support team, which we encourage you to call if you were tested positive, if you were exposed, or if you have questions about potentially being positive or being exposed. General COVID questions, help getting linked to resources, finding testing or vaccine sites, please call 211, and I've included the website. Dr. Paul Cieslak, our medical director of our communicable diseases and public health, has a 3-minute video explaining why we have breakthrough cases and why we can expect to see more breakthrough cases as more members of our community are vaccinated. And it's simply due to the math of it. And so if you are interested in that and curious about the math of that, he explains that really succinctly. And then at the bottom, again, is the link to the CDC's website that has the COVID community level. The last slide is covidvaccine.org. If you're looking for a vaccine or a booster dose or want to send those resources to your communities, please give them this link. We have been hearing that some community providers are only offering one of the vaccine types, either Moderna or Pfizer, to their community. All OHA vaccine events offer both choices, either Moderna and both Moderna and Pfizer, so you can choose. So please, if you have a strong preference for which vaccine you'd like your child to get, call your provider before you go to make sure that they are offering that vaccine. And then I have included, as always, the Safe Strong Oregon link, which exists in multiple languages and has information ranging from COVID vaccine to how to stay safe during COVID to resources for your community, as well as tips and resources to support your emotional well-being. That is all of my slides, and I welcome questions if there are any.
Hi, Dr. Meg. Thank you. We do have a couple questions for you. First, when you had stated that child care centers recorded and school-based programs should report when they have 10 cases, the question was, in what time period? Is that in a week or 10 cases in a month? Or so can you explain that a little bit? That was a great question.
Thank you for that clarifying question. They should report as soon as they meet that threshold. So as soon as they have, at any given time, at least 10 children or staff out, they should report that threshold. So if you have a couple of kids out at the beginning of the month and a couple of staff out at the end of the month, the likelihood that they were out for the same reason is probably lower. If it's sort of within the same general time frame or out at the same time, they should report. And as you're getting used to reporting these thresholds, again, we encourage you to to reach out to your LPHA whenever. So if you have 5 kids out one week and then a couple come back and a couple more kids out, that is reason to report. If you just see an exceptionally large number of people out in a relatively short period of time, your programs in your communities best, please connect with your LPHA. Again, this is not because LPHAs think that, infection prevention hasn't happened. It's really to ensure that you all have the support you need and that we're aware of how infectious diseases are spreading in our communities. So to be really clear, there is not a specific time frame of how many kids over what period, but generally clustered around the same number, the same days to weeks.
And I also want to add, Ronnie, because you used the word cases, to make sure folks understand the changes to the reporting threshold. We're not reporting COVID cases. We're not looking for 3 cases and then you report 3 COVID cases and then you report. What we're looking for now is kids and staff that are out because they're sick with some kind of respiratory symptoms. So we're not expecting programs to report positive cases only when kids and staff are out because they're sick with COVID-like symptoms.
Excellent, Miriam. Thank you for that. So we have another question. Could you please confirm that while these are not published guidelines, they are effective immediately?
Miriam, you want to take that one?
So it's a little complicated because we want to make sure that you all have the information as quickly as we can get it to you, but we have not published the guidelines. So local public health authority aren't going to expect you to make this shift immediately. So it's not a requirement as of today, but if you start changing the way you report to public health now, that is okay. If you wait until the guidelines are posted and ready for you, that is also okay. Meg, would you agree?
I would agree. I think that's exactly right. And the only addition that I wanted to add is that these are the reporting thresholds that K-12 schools have moved to, and so summer schools have moved to. And again, it's because we know there's so much COVID in our community that reporting just one case of COVID just doesn't really make sense, and it's not frankly all that helpful or is going to change what we need to do. But as Miriam emphasized, and thank you for doing so, we are shifting from reporting COVID to reporting respiratory illness in general. And then if you know the COVID status, you can share that as well.
Thank you. So do you recommend indoor masking requirements for children who are not going to be vaccinated or are not vaccinated?
When there's high levels of transmission in the community, yes. When there's low levels of transmission in the community, I think that is a discussion to have among families and within your program. I very much appreciate that it can be confusing, maybe even isolating to have some kids being required to wear a mask and others not. At the same time, I also appreciate that programs have a culture and value system that you teach to your kids and you expect from your families. And so I think that I'm going to say that that's personal to the families, to your communities. But when there is particularly medium or high levels of COVID transmission, I would recommend that.
Thank you. Miriam, I think this one might be for you. At what point can we drop COVID policy like stable groups, masking, etc.? Once a certain percentage of the school is vaccinated or in January, can you shed some light on that?
Stable groups have not been a requirement for quite some time. Masking is not a requirement. Like Meg said, there are some situations where masking would be recommended, especially if your community is in that high community level risk.
Thank you, Miriam.
Ronnie, I also wanted to add to remind folks that on our website, if your program does need to move to considering masking for kiddos in care, we have developed some resources, some flyers that are on our website that you can maybe use to help share this information with families and explain why you're making that choice. You can find those on the COVID-19 resources for providers tab, I believe it is, or feel free to reach out to your licensor and they can point you in the right direction.
Thank you, Miriam. Allison put that in the chat as you were naming it. That's just our Allison. Karina, you have a couple questions that you would like to ask for the audience.
Yes, thank you, Ronnie. We have a question that was submitted in Spanish asking, can we have air purifiers in care centers?
Is that like, can you get support for buying air purifiers, or is it okay to have air purifiers? And I guess I will answer the last one and then, oh yeah, I'm sorry, Karina, please.
Yeah, I'm reading it as, can you have air purifiers?
Absolutely. There's no harm to kids to have air purifiers. And in fact, it's recommended. Again, it leads to higher quality of air, which we know leads to a whole bunch of health benefits for people of all ages. Miriam, what did you want to add to that?
Yeah, I was just going to add there are no licensing regulations against using air purifiers.
Okay, Karina, you have one more?
Or no, the second one there was actually clarification. Back to you, Ronnie.
Thank you. So let's see. Do the unvaccinated pose a greater risk of spreading COVID than do the vaccinated population?
No, is the short answer. And I appreciate that might be befuddling or even frustrating. But again, the real effectiveness of these vaccines is reducing your risk of COVID. Absolutely. If you look at the data of who's contracting COVID, those who are unvaccinated are at much greater risk for contracting COVID. But we know that even more so, these vaccines are effective at really preventing severe COVID. If you get COVID, regardless of if you are vaccinated or not, and your body is mounting enough of a response that you are test positive for COVID or have symptoms for COVID, you can spread COVID. And again, we know that you can be asymptomatic, positive for COVID, again, whether you're vaccinated or not, and can spread COVID. So there is no data at this time that vaccinated individuals are at less risk of transmitting COVID, but because vaccinated individuals are at less risk of getting COVID, then on the whole, in the community, vaccinated individuals spread COVID less simply because they don't get COVID as often.
Thank you. So could you please clarify this, that vaccinations are a suggestion for young children, but not a requirement? Is that correct?
Miriam, yes, I mean, that's correct at this time. And I don't know what the discussions are at ELD about making it a requirement, but again, none at this time. And that's where we are in public health. They are recommended, we encourage them, but they're not required. And Miriam, anything you wanted to add to that?
No, we're following OHA's lead on requiring vaccination. So we don't anticipate that being a requirement.
And I will say at this point, there's no discussion at OHA that at least I'm a part of that is discussing making it required for young kids to participate in childcare and have a COVID vaccine. I will say that we know that there are other vaccines that we ask that children get in order to participate in schools and childcare. And if at some point in time the COVID vaccine is one of those, that's a possibility. But I don't anticipate that happening before it has full FDA approval and not the emergency use authorization at the very earliest, if at all.
Okay, thank you. So this will be our last question before we move on to our next topic. And this actually is a two-part question. It says, can you talk about home testing and the recommendations to enforce testing among younger ages? And the second part was, do you know if the 90-day positive result is still true after testing positive?
I'm going to answer those in reverse order. So at this time, OHA is aligning with the CDC that says if you have had COVID, if you test positive within the 90-day window, we count that as remnants of the same infection and not a new infection. So the 90-day window still holds. I will tell you anecdotally, and the data is showing that reinfection within that 90 days, particularly between day 45 and 90, or after 6 weeks, after a month and a half, 6 weeks, is becoming more likely, but we are still aligning with CDC on maintaining the 90-day period between COVID infections. So don't be surprised if you get reinfected, but again, we're counting the 90-day. The first question about home testing and requiring testing for young children, did I get that right, Ronnie?
Yes, you got that right.
So home testing is great. Home testing is accessible, it's easy, you can still get free tests from the federal government, and from your insurance. We strongly recommend that you max out your insurance allotment of home testing and your federal government allotment of home test kits, and you use them. And you use them if you have any symptoms. They are, for individuals who are symptomatic, they are nearly as sensitive as the PCR testing. So home testing, remember, are antigen testing, and the PCR testing that you can get at a testing event or at a clinical setting are PCR, and PCR tests can detect lower levels of COVID. If you have enough COVID to be symptomatic, though, both tests are really pretty equally accurate. So yeah, use home testing, trust home testing, particularly if you have symptoms. In terms of requiring kids to get tested, I'm not sure I understand the question or the intent of the question, and so I'm not entirely sure how to answer that one.
Yeah, I think there might have been another part where they've had a parent say that they didn't want the test on their children.
Yeah, there is no authority that we have to require people to get tested. There are clear guidelines in the child care exclusion guidance that if a kid has 2 core symptoms of COVID, regardless if they test positive or not, they should be excluded from child care. Otherwise, I think so much about COVID management is negotiation, from the mitigation strategies to getting tested, to getting vaccinated, and continuing to foster your relationships, leverage your relationships and trust, bring in trusted messengers, and have that conversation with families is the best way to go. So I'm not going to endorse that you require families to get tested, but I appreciate that can present some challenges.
Thank you.
Mary, any additional thoughts on that?
Did you have anything you want to add before we move on?
I think Meg put it beautifully. I do want to encourage programs to feel empowered to make choices that you feel are the best to make for all of the children in your care. And sometimes, like Meg said, that means a little bit of extra talking to some families that may feel more uncomfortable with. But the recommendation is, if there are more than one COVID-like symptoms, that we send kiddos home, and the recommendation is that they get tested.
Thank you all. I really appreciate the time and your questions, and as always, don't hesitate to reach out with more questions. Thank you.
Thank you so much, Dr. Meg and Miriam. We'll go ahead and transition here to Allison Delory, who will walk us through a few slides.
Thank you, Karina, and thank you, Dr. Carey and Miriam. That was very helpful. We are a little behind schedule, so I'm going to quickly talk to you all about Department of Early Learning and Care engagement that has happened so far and that will be happening soon. And I'll drop some links in the chat so that you know where to go for more information. We can go to the next slide, Miriam. Okay, so this infographic is available on our website, and it outlines the big change from Early Learning Division sitting under the Department of Education to becoming our own agency, the Department of Early Learning and Care. This is all due to House Bill 3073, which passed a little over a year ago. And the transition will officially take place on July 1st, 2023. So just about a year to go. And this transition, we're excited about it. It's going to allow us to expand and strengthen the early learning systems to better serve Oregon's children and families and childcare providers. This resource, this infographic, is available in multiple languages on the website. So if you want to take a closer look, you can zoom in. I know it's very small on your screen right now, but that is available to you. We can go to the next slide, Miriam. Okay, so engagement that we've done so far regarding the Department of Early Learning and Care. In June and early July, we were engaging people on the draft mission, vision, and values statements for the new agency. And our goal with this engagement was really just to listen and hear people's reflections, thoughts, feedback on the draft statements. We did outreach with a number of people across the state. It was important to us that we heard from families, childcare providers, advocates, grantees, employees within the agency, to really make sure that these statements align with the communities that we're serving and that we're working with. Go to the next slide. So there were two components to the mission, vision, values engagement. I know some of you participated, and thank you for doing so. We had a feedback survey that was open from June 2nd to June 21st, and we had just under 400 responses. And we followed up that survey with community conversations. And in both of these engagements, we really just tried to ask open-ended questions. We were seeking clarity of language, making sure that the statements align with personal goals so that it really is reflective of our state and the early learning system that we'll be serving. Go to the next slide. So right now we're in the process of analyzing all of the data from these engagement sessions. We've got a lot of qualitative and quantitative data that we're sorting through. We are working on a report. We will share that on our website, and I apologize, it's yellow on your screen. That's probably hard to read, but it's the same page that's in the chat here, OregonEarlyLearning.com/HB3073. So you can find more updates there, and we'll be circling back with the people that we engaged with so they can see the changes that were made based on your feedback. If you have any other questions about DELC, you can email delc.info@ode.oregon.gov, and someone will get back to you. But please be on the lookout. This is the first of many engagement opportunities. So much more to come, and we hope to hear from you all in future sessions.
Thank you, Allison. We'll go ahead and hand it over to Katrina if you want to introduce yourself, and thanks for joining us. This is your first time here, so welcome.
It is. Thank you, Karina. Yes, I'm Katrina Miller. I am the infant and early childhood mental health specialist with the ELD, and am helping to build the new early childhood suspension and expulsion prevention program. And I know this is a program and legislation that passed in 2021 that a lot of people have a lot of interest in, a lot of questions, a lot of concerns. So this is just the first. I'm sure I'll be back to these sessions many times. So this is just the first. Let's go to the next slide. So just a couple of things, like going into this is some of the assumptions that I bring, that we are bringing to this work, is we know, and I don't need to tell you this, but we know, all of us know, caring for young children is hard work. It's usually underpaid. It's usually under-supported. We also know young children, they hit, they kick, they bite, they cry. They have other behaviors that make it challenging for us, the grown-ups who are working with them. We also know that young children get suspended and expelled because of these same behaviors. And sometimes they are developmentally appropriate behaviors. Oftentimes they're developmentally appropriate behaviors. We also know that it is children, Black and brown children get suspended and expelled for the same behaviors more often than their white peers. And children with disabilities get suspended at a much higher rates. We also know that the care that young children receive in their first years has a lifelong impact. And so what we want to do is we want to provide support for everyone. Everyone needs more support. The children need more support, the families need more support, and you, the providers, need more support. So the program is not intended to make life more difficult for you by taking suspension and expulsion away. It is intended to provide more supports, to support you, to support children, to support families. The next slide, please. I think in some ways, we have the name of the program, it's the Suspension and Expulsion Prevention Program. It tells us about what we're taking away. But what if we called it instead the making sure early childhood providers have the training, coaching, consultation, and other supports they need to be able to support every child? It's a little awkward to say, but that's the goal. And let's go on to the next slide. So this is just a quick one possible scenario, one example. And this doesn't show the whole range of possibilities, but just to give you an idea of how we're thinking about this. So let's say that you as a provider, you have a child in your program who is, you've identified a need for support. Maybe this is a toddler who's never been in care before and is experiencing a lot of separation anxiety. Maybe it's a child that has experienced some sort of trauma or change in the family, and their behavior is starting to be concerning or disruptive, and you identify a need for support. So we will have a warm line where you can go and you can submit a request for support. It will be a website where you can just input the information and say, I need some support. The request will be received, and behind the scenes, we'll have teams of mental health consultants, the acronym there, infant and early childhood mental health consultants, and other technical assistance providers. So that would be our coaches at CCR&Rs and other similar roles. But people behind the scenes will collaborate to identify who is the best person to respond to your request for support. Then whoever that person is will contact you, and then support is provided. And that support will look different in each situation because each and every situation is different. But it'll be tailored to meet what the individual concerns are for your program for that child. The goal is that you, the provider, feel supported. And the goal also is that we maintain the child's placement so that the child has the stability of being in a familiar place and can settle in and learn and grow. Occasionally, there may be some times where a child can't be maintained in a particular location, a particular program. And when that's the case, if we can develop a transition plan and make sure that that transition happens carefully, then that is not something that will count as a suspension or expulsion. So that's again just one kind of scenario of what this might look like. But what I'm hoping that you can hear is that this is about providing more supports, not about leaving you hanging with challenging children. And then let's see, I think one more slide. We'll have a lot more of community engagement sessions coming up At the end, the survey that will be, the link to the survey that will be provided, there's a place to enter your name and your contact information if you would like to be included or invited to those other engagement sessions. You're also welcome to email me, and my email is there on the screen. I think that's it.
Thank you, Katrina. Ronnie, would you please facilitate our questions? Appreciate it.
Sure. So what requirements and supports will be in place for parents, and will their participation be expected?
That's a great question. We can't, we're not in a position where we can require parents to participate in services. But what we're trying to work with, and some of these things are the things we'll be developing over time, is how can we provide support to you as the provider, even in the situations where we can't, address the needs of us. It's a little hard to, I'm getting tongue-tied here, but how do we still support you in sort of what we call program level supports or classroom level supports, whether or not a family is on board. That being said, what we don't want to do ever is to go behind families' backs. So that's something that we'll be working out, we'll be figuring it out over time. But I do recognize the complications there.
Okay, thank you. So let's see. Does this apply to early childhood only, or does it include school age, knowing that some of us can work with school staff?
Great, good question. This is early childhood. This is from birth up to, or 6 weeks up to kindergarten transition.
Thank you. So do you know what is the turnaround time for assistance once they request it?
Great question. I don't know that yet because we haven't created it yet, but it will be, that is something that is definitely on our list of things to make sure that we have a prompt turnaround.
Okay, thank you. Karina, is it time to go, or do we have time for one more?
It's time to go.
Okay, thank you.
Thank you. And Katrina, if you want to just speak on that, because I think I see one or two other questions that are very specific to the program implementation piece. And I've been in some of those conversations, so just wanted to let you speak to that piece a little bit more.
Sorry, which part of
just to expand on like that, we're not quite at the program implementation place, right? So there's a lot of questions that are still being asked about the timing and the when there.
Yes. Yes, thank you. So we are we're going as fast as we can behind the scenes. We have a lot of program development to do, a lot of the creation of the supports. So there aren't any of the requirements to request support have not gone into effect and will not go into effect for some time yet. And we'll provide clear notification when that does, but we are building up the supports. We'll have a lot more kind of staff, a team of mental health consultants available in the community to provide supports. So more details coming over time. The supports are not currently available, and the requirement to seek the supports is also not yet in place. I hope that makes sense.
Thank you so much, Katrina. I recognize that it is 7 o'clock, and just to be respectful of our interpreters, we'll go ahead and jump to the next slide, which is our final piece of information. And it is a quick reminder about the application deadline that is upcoming for the Preschool Promise slots. So the deadline for the application is Thursday, July 21st at 11:59. We spoke about Preschool Promise and the different programs that we provide as Early Learning Division at our previous provider information session. So you are welcome to go to our website and find that recording on there as well if you would like to review that. But we wanted to just encourage you to apply if you're interested. Grant applications are open for new and existing Preschool Promise providers. And just, Preschool Promise is a publicly funded program and it serves 3 and 4-year-olds. So there is more information on our website, and we'll be dropping those links here and on Facebook. There was a question on Facebook of how do we send some of this information to parents? Just a reminder that these slides will be on our website by the end of tomorrow. We usually like to post these soon after, as well as the recording if you want to go back and rewatch or share some of this information. And we encourage you lastly to please subscribe to our childcare provider updates to receive the latest information. This is where you'll get updates about RFA applications. Any last comments from anyone? I believe this concludes our meeting for the evening. Again, thank you for joining us. We will be back in September. For our next provider information session. And if you missed anything, please go back to the recording and find the slides on our website. Thank you so much. May you have a wonderful evening, and we will see you all soon.